Hi, everyone. Thank you so much for joining us for today's HTRC Education Series session. My name is Haley Bell. I'm the Program Manager for the Heartland Telehealth Resource Center, and I'll be hosting today's session. Just a few quick notes before we get started. The session is being recorded, and we'll share it with you afterwards in that follow-up email along with Rochelle's slides. Please use the chat to ask any questions that you may have. We will get to those at the end of the presentation. And then if you would like a completion certificate, please email us at htrc@kumc.edu. So to get started, I'd like to introduce our speaker. She's one that you may be familiar with, Rochelle Marding. Rochelle is a local attorney who's also a registered health information administrator and certified medical coder. Her practice focuses on medical coding, billing, and reimbursement, HIPAA privacy and security, health information management, and regulatory compliance. So we're very fortunate to have Rochelle back with us today. So I will go ahead and turn it over to her.
Hey, thanks, Haley. I know whenever we get a lot of folks on the Zoom meeting, sometimes my video is a little bit slow and I can see it's lagging. So I'm going to say hi really quickly and turn that video off so the video lag is not distracting you throughout the session this afternoon. But great to be with you again. Those of you who've been on our HTRC calls before know that this is one of my favorite topics to talk about throughout the year. I'm not sure exactly when it was that I became so fascinated with the Federal Register and Medicare's proposed and final rules, but it's something that every year in July, when the proposed rule for the upcoming year comes out from Medicare, I immediately have to sit down and read it. And there's only so much information in these proposed rules. So I'm excited to walk through that with you, as well as talk to you about some policy updates outside of the physician fee schedule for Medicare, but that are very time pertinent for those of us who are working in the telehealth space. So first and foremost, I want to start with a reminder that every year CMS takes requests to add services to the list of covered telehealth services for the next calendar year. That deadline will be February 10th of 2026. That is to have your request considered for the 2027 fee schedule. So you get your requests in by February 6th of services that you want to suggest that CMS cover and pay as telehealth services under the Medicare program. Medicare considers those between February and July and will release the proposed rule each year in July based on the requests that they receive timely. CMS does periodically look at services on their own, particularly new codes that they're creating for an upcoming year, and they will assess whether they meet criteria for telehealth, but by and large really rely on the community and on the industry to bring those requests to the agency to take a look at. Before I dive into the 2026 physician fee schedule proposed rules, I did want to take just a few minutes to give an update on where we stand in terms of federal telehealth policy more broadly. Now, there are certain pieces of telehealth rules under the Medicare program that CMS as an agency can update or change through rulemaking. And then there are certain provisions of telehealth policy that are beyond CMS's authority because they live in federal statutes, which means it takes a literal act of Congress to make changes to certain telehealth policies. And at the end of last year, at the end of 2024, December 31st was a big date in telehealth because absent an act of Congress, a lot of the flexibilities that we have had for telehealth services throughout the COVID-19 public health emergency and even afterwards would have expired. With about 10 days before those flexibilities would have expired, we got a temporary 90-day extension to those flexibilities. So we could take a small sigh of relief at the end of 2024, but not quite a deep breath because we only had 90 days. And then again in March of 2025, Congress acted again to release another temporary extension to those flexibilities. Well, September 30th is our next big date. That is when the current extension to telehealth flexibilities would end absent another act of Congress. So here's what this looks like in terms of those policies that are on the table to potentially expire if Congress doesn't pass a bill before September 30th. So on September 30th, we've had extensions. Let me say that another way. We have had flexibilities and waivers throughout the COVID-19 public health emergency that allows telehealth services to be delivered to patients who are in their home. Now, that is a provision within the federal statute, and it takes an act of Congress. CMS, Medicare, does not have the authority to change that with very, very limited exception. And so after the public health emergency ended, it has been Congress that has been incrementally extending that flexibility to be able to see patients who are at home for telehealth services. If that flexibility goes away October 1st of this year, if there is no act of Congress extending or making that flexibility permanent, then we will go back to pre-COVID-19 public health emergency rules. And if you can remember that far back, there is a list of eligible originating sites. Those eligible originating sites are locations like physician offices or community mental health centers or FQHCs and RHCs where a patient must be physically located at the time of a telehealth service to be a covered Medicare benefit. Right now, because of waivers during COVID-19 and extensions by Congress after the public health emergency ended, there are no geographic restrictions for the originating site. That's the site where the patient is located for a telehealth service to be paid by Medicare. Prior to COVID-19 waivers and flexibilities, a patient had to be located in what I'll loosely call a rural geographic area. There's a very specific statutory definition of what that means, or a healthcare provider shortage area. But due to the flexibilities and waivers during COVID, due to the extensions when the public health emergency ended, those geographic limits have been waived since COVID-19 and remain waived. However, absent an act of Congress, they would come back on October 1st of this year. There is also a statutory list that can only be changed by Congress of the eligible healthcare professionals or entities that can serve as distant site telehealth providers. So distant site, that is the professional who is remoting in to perform the telehealth visit, that's billing for the professional services. And those telehealth services or distant site providers can be any eligible provider through September 30th of 2025. Absent an act of Congress, only those professionals and disciplines that were eligible to bill telehealth prior to COVID will be eligible to perform telehealth on October 1. That is true even if the services that certain disciplines provide are on the list of covered telehealth services. That becomes particularly important for speech, occupational, and physical therapy, because those disciplines have CPT codes that are covered telehealth services. But on October 1 of 2025, if Congress does not pass an act to extend flexibilities, those disciplines will no longer be eligible distant site billers and providers of telehealth services under the Medicare program. RHCs and FQHCs would be significantly impacted by that, because RHCs and FQHCs are also not statutorily eligible to provide telehealth as distant site providers. They have always been able to host the patient in their clinic for a telehealth visit performed by someone else at another distant site. But on October 1, if there is no federal legislation, RHCs and FQHCs would not be able to be the distant site provider and biller of telehealth services under the Medicare program. Another flexibility that we have right now involves what we've been sort of anecdotally calling the in-person visit requirement for certain mental behavioral telehealth services. Now, this is a really tricky one. This rule came into effect, in around 2019 or 2020. And at that time, patients could receive telehealth services in their home for substance use disorder issues or mental behavioral conditions that co-occur with substance use disorder. And that was a really narrow exception that allowed patients to be seen in their home for telehealth services under the Medicare program even before the telehealth waivers. And that will be true after September 30th, 2025. That will still be true in that circumstance on October 1 of 2025. Those mental behavioral conditions that co-occur with substance use disorder or are themselves a substance use disorder do not require an in-person visit under the Medicare program prior to having a telehealth service and can be rendered to a patient at home under the Medicare program. That is a permanent ability that is already memorialized in federal law. But what would change is a slight twist on that scenario. If a patient is being seen for mental or behavioral conditions that do not co-occur with substance use disorders, the law that was passed requires in that circumstance that there is an in-person, a physically in-person visit with the patient within 6 months prior to that first telehealth visit in order to allow the patient to be seen at home and have a covered visit. That in-person visit requirement went into effect, but was essentially waived almost as quickly as it went into effect because COVID hit. And it has continued to be waived since then. But absent an act of Congress would come back into effect on October 1 of 2025. What we did learn a couple of years ago through Medicare policy, as we were looking at coming up to a potential expiration of these flexibilities even a year or two ago, CMS said that they would grandfather in patients who had been seen at home for mental behavioral telehealth services throughout the duration of the COVID pandemic and not require a new in-person visit if those flexibilities went away. However, any new patients that were going to be seen at home for a mental behavioral telehealth service would need to have an in-person visit within 6 months. Now, for FQHCs and RHCs, right now, that in-person visit requirement actually goes through December 31st of 2025, and is not required, but absent an act of Congress would again be required January 1 of 2026. Oh, one more piece here. The third bullet here at the bottom, a visit that is not a behavioral or mental health telehealth service under the Medicare program can continue to be delivered using audio-only technology through September 30th of 2025. However, that if there is not a change to federal policy, that may go away October 1 of 2025. Audio only is, I mean, that could be two-way, real-time, like a telephone call. It could be like a virtual meeting platform or format. It still has to be synchronous, meaning real-time. So email messages, portal messages, those types of asynchronous communications won't count. Now, whenever we're having these sessions about flexibilities and flexibilities going away, I always get questions about prescription drugs and particularly controlled substances. And what is the status of flexibilities surrounding the ability to prescribe controlled substances in the course of a telehealth visit? This was, it's a different agency that administers these rules. It's under the DEA. But under the DEA, there have also been extensions to waivers that we had during COVID that would allow professionals to prescribe controlled substances in the course of a telehealth visit, even if they had not had an in-person visit with the patient previously. So those flexibilities continue right now through the end of this calendar year. What we would need for that to continue beyond December 31st is not actually an act of Congress, it is a rule from the Drug Enforcement Administration. All right, so we've got just days over 1 month left before those flexibilities potentially expire. There is already legislation on the table that's been introduced actually back in March that would make those exact same flexibilities that we've been enjoying throughout COVID and as extensions following the expiration of the public health emergency, would make those permanent under what right now is provisions of the Social Security Act. Right now, the status of that bill is only at the very first stage of having been introduced. It certainly can move quickly, but we're going to have to watch and follow federal legislation to see what happens on October 1st with a lot of those flexibilities under the Medicare program. And so I'm going to shift gears a little bit and I'm going to talk about the Medicare physician fee schedule, the proposed rules. So everything we talk about today is not final yet. It is not set in stone, only proposed for what may go into effect in 2026 under the Medicare program. The final rule typically comes out about the first week of November, and that's when we'll see kind of where all of these provisions, will land. So the first piece I want to talk about is rates under the proposed physician fee schedule. There's a couple interesting concepts about rates that were in the proposed rule that we really haven't seen in prior years. One of them is a distinction in the conversion factor that will dictate a lot of our professional rates, depending on whether the professional or the group that they practice within is an advanced payment model participant. And many groups in our area, especially smaller practices, are not yet advanced practice model participants. They're not in a sort of pilot payment program with Medicare. And so they would be looking at an increase in their conversion factor rate, which is great. It's just not as much of an increase as those professionals or practices that do participate in advanced payment models. So we'd have it's projected to be about a 3.62% increase in the conversion factor to $33.42. It's one of the first times they're even proposing an increase in quite a few years. So that part's good news. The originating site fee, that's the fee for the location where the patient is situated at the time of a telehealth service. Sometimes you'll see it called the facility fee for telehealth. That's also going up. It's going up from $31.01 to $31.85, or at least that's the proposal right now. But this last piece I found really interesting. There is a brand new concept in the proposed rule called an efficiency adjustment. And what CMS is proposing to do is look at how much more efficient we have gotten at delivering healthcare services and adjust the work RVU component, or the intra-service portion of physician time, that they expect is being improved through increased efficiencies. So in other words, they're taking the value of services like evaluation and management, and they're looking for the component of that value that is comprised of physician work, and specifically physician time. And with the understanding or the impression that physicians and other professionals are becoming more efficient, CMS is essentially applying a negative adjustment to reduce the value of that professional time component. And so that would be reevaluated every couple of years, which I thought was just kind of an interesting, almost an offset to what they're proposing as an increase to the conversion factor, and will essentially take a higher conversion factor and potentially be multiplying it by lower RVU values. So the true net effect is really hard to get a hold of or get our heads around. So let me switch gears to just telehealth policy in particular in the proposed rule. One of the things CMS is looking at doing is proposing a process that would make it a little more streamlined, a little simpler to propose codes to be added to the list of covered telehealth services. That's that February 10th, 2026 deadline to submit your requests if you have anything you would like CMS to consider adding to the list of covered telehealth services. So what CMS would like to do, they currently have a 5-step process where they look at a bunch of different criteria and figure out if a requester's submission meets each of these 5 steps. And CMS says, look, based on feedback from interested parties and its own review, it really doesn't account for what CMS believes is a vital role of professional judgment to be exercised by physicians and other practitioners in determining when it is appropriate, and in their clinical judgment, it's appropriate to deliver a service via telehealth. Now, I want to pause here for just a second. This is a theme that I saw repeatedly in the proposed rule. This piece that there's a professional judgment being exercised by professionals that CMS defers to in a number of their telehealth policies. I think that's really interesting. I thought there were a couple good quotes that I wanted to pull out. CMS says, we believe that physicians and other practitioners, given their in-depth knowledge of their patients' clinical needs, they are the ones in the best position to exercise their judgment and determine whether a service can be safely furnished via telehealth, or whether furnishing a service via telehealth will provide clinical benefit justifying its use. I read this initially and had a positive reaction about deferring to professionals' judgment, but I'll put a little asterisk on that, because the other thing that came to mind immediately for me is that this appears to create a little bit of an obligation or a burden on professionals to demonstrate for their telehealth services that they are safe and that they are effective, the clinical benefit. And those are elements of medical necessity under the Medicare program. Services that are safe, that are effective, that are not experimental or investigational, that meet but do not exceed the patient's needs. That's how we determine whether a service is reasonable and necessary for coverage and payment under Medicare. So to me, this quote in some ways is good, but in some ways I think may create some additional documentation expectations or burden when and if CMS or other contractors are reviewing services to ensure that we're delivered via telehealth, to ensure that they meet medical necessity standards. So here's what CMS said in terms of the request to add services to the list of covered telehealth, knowing that they really wanted to defer more to professionals' judgment and less be an agency that's sort of imposing clinical judgment into the policy that it's making. CMS said we're going to take out 2 steps in the process. One of those today looks at whether the requested service kind of maps or matches other items or services that are already on the list of covered telehealth. That's no longer or would no longer be a part of the consideration if this proposal were finalized. The other piece that CMS would eliminate in the process is whether there is evidence of clinical benefit delivering that particular requested service in a telehealth format that would be analogous to the clinical benefit of an in-person service. So I think particularly with this step 5 getting removed out of the process potentially, CMS is saying we're really going to rely on the professionals, and as technology changes so rapidly, they have to be the ones to decide that there's clinical benefit analogous to what the clinical benefit would be if you had delivered that particular service in person. So instead, what CMS would do is any services that are on the Medicare list today, we will no longer have a distinction between permanently covered telehealth services and provisionally covered. Provisionally covered telehealth services was really a product of the COVID-19 public health emergency, and lots of services were added to the list on sort of a temporary basis during the public health emergency. Then CMS left them kind of provisionally while CMS was deciding whether to make them permanently eligible telehealth services or to drop off the list. That distinction would no longer exist. Anything that is provisional would now be considered permanent. However, permanent is sort of in air quotes because even though it is on the list of permanently covered telehealth services, that doesn't mean that CMS can't remove that service later on. It just means it's not sort of scheduled with an automatic expiration. So anything that is currently covered as a telehealth service, if this proposal is finalized, would be on the, I'm going to do air quotes, quote unquote, permanently covered list of Medicare telehealth services. So a couple important pieces of this that I had pulled out of the Federal Register. CMS is saying, just remember, the addition of a service to that list doesn't mean that it is appropriate to be furnished via telehealth to every Medicare patient in every clinical scenario. That one really caught me, that really stood out to me when I was reading the Federal Register, because what that means to me in sort of my legal realm when I'm working with providers and defending against audits, I can see this language being grasped onto by a Medicare contractor saying the provider needs to demonstrate that it was appropriate to have delivered this particular service to this particular patient on this particular day in order for it to be reasonable and necessary. So it stood out to me as maybe starting to create additional documentation expectations for providers that I think we need to pay attention to. The next piece, or another piece I should say, that really stood out to me surrounding this policy is that we, CMS, believe that healthcare professionals are going to consider important safety factors when they are deciding the right modality to address their patients' needs: in person, face to face, telehealth, e-visits, etc. And CMS says, we really encourage professionals to review and use clinical practice guidelines, peer-reviewed literature, and similar materials to illustrate the typical setting, the types of patients, and the clinical scenarios, excuse me, when you would expect clinical benefit from telehealth services. Put a big exclamation mark on that. I flagged it, I tabbed it, I highlighted it in my electronic PDF document, because what that tells me is providers that are using telehealth services probably want to dig up some of their professional society or other research, literature, studies that support the way that they're using telehealth. And if there's an audit down the road that may question whether you're using telehealth in appropriate clinical scenarios for appropriate populations of patients, you'll have that research in your back pocket, ready to demonstrate that you're using telehealth appropriately. The last couple of years, CMS really has rejected most of the proposals to add services to the list of covered telehealth services. But in contrast to that, CMS did actually introduce a few new proposals this year to add to the list of covered telehealth. Several of those were CPT codes that were new CPT codes in 2025. CPT codes that were brand new telehealth services in 2025. And CMS received a lot of requests to add those to the list of covered telehealth services under the Medicare program. For those requests, though, CMS rejected or denied the request to add them under the Medicare program because CMS and Medicare are actually not recognizing those CPT codes at all, whether they were, in person or via telehealth. So they weren't added to the list. And this just shows you, if I can get, let me see if I can get a pointer or something here. There's my laser pointer. These are some of the new CPT codes that were added in 2025. And you can see they describe various modalities and links of telehealth services to the CPT book. CMS chose not to recognize or use those codes in the Medicare program in 2025, nor in 2026. However, CMS is proposing to add several other codes to the list of covered telehealth services: multiple group psychotherapy services, group behavioral counseling for obesity, an inherent complexity of infectious disease management, and then this, I'm not sure what 92622 is, auditory osseointegrated sound processor. If anybody's in that particular specialty, you can add to the chat and tell us what that service is. But one of the things you're going to see later on that we'll get to is a theme here when we look at the behavioral counseling for obesity. There is certainly a theme throughout the proposed rule focusing on chronic disease management. And that's really messaging that we've seen reiterated and emphasized throughout the entire administration, and how they want to approach different public health benefit programs. And so I think that's one of the reasons we saw that obesity counseling service added to the list of telehealth. So let me back up. Prior to the public health emergency, there were certain services that could be delivered via telehealth, but Medicare placed limits on how frequently a particular service could be delivered via telehealth. For example, hospital services could be delivered in a telehealth modality no more often than once every 3 days. Visits to patients in skilled nursing or other long-term care facility settings could be rendered. At one point, it was no more often than once every 30 days. At one point, it was once every 14 days. Those frequency limits were waived. We were given flexibility to see patients in those settings more frequently via telehealth. And those flexibilities have continued even after the formal public health emergency ended. CMS says, here's this theme again. We believe that physicians and other professionals with the greatest familiarity and insights into the needs of their patients, they can use their own complex professional judgment to determine whether that they can safely furnish services via telehealth, given the entirety of circumstances like an emergent situation that you need to call in via telehealth to intervene immediately, for example, including clinical profile needs of the patients to determine the right modality. Again, kind of putting that deference back on the professionals, but also maybe potentially creating a little bit of a burden or a responsibility in documentation to explain that complex professional judgment, the safety and the efficacy under the entirety of the circumstances and what those circumstances are. The proposal would be to completely and permanently eliminate those frequency limitations on how often you can use telehealth as a modality to see patients. But there's this kind of exclamation mark. Just because CMS doesn't place a formal limit on the frequency, they're cautioning. It does not mean that the services would be appropriate to deliver in a telehealth format to every patient in every clinical scenario. And I again think that is placing some responsibility on professionals to explain why it was appropriate for that patient in that scenario at that time. Okay, so then we have some provisions on the supervision level for telehealth. Direct supervision typically means that a provider is in the office suite where the patient is located and available to intervene if needed. That concept doesn't really fit well in the telehealth format. I mean, the whole point of telehealth is it's mobile, it's flexible. We can be rendering care from different locations. And so CMS is trying to address or consider, what does supervision of a telehealth service look like? And so for next year, CMS is proposing to permanently adopt a definition that we have now been using for several years by way of waivers and flexibilities during the public health emergency, that says the immediate availability component can be met using a telehealth technology or virtual presence. So as long as the provider is able to intervene via telehealth, that can meet the immediate availability requirement. Now, there is an exception for services that have a 10 or a 90-day global period. Those are typically surgical procedures. I don't think the exception for 90-day global periods will really have a significant impact because those are surgeries that are typically done in the hospital setting. And so you would typically have a provider who's on site seeing the patient in the facility. But I do think this brand new caveat or exception for services that have a global surgery indicator of 10 days might have a very significant impact for primary care and other clinic settings and practices. When you do a wart removal, a lesion removal, earwax removal, minor procedures in the clinic or in the office setting, those minor procedures typically have a global surgery indicator of 10 days. And what that would mean is, in order to bill a service under a supervising provider, direct supervision would be needed, and that provider could not meet the direct supervision requirement through virtual presence alone, through the ability to just intervene, even with audio visual technology. The provider would need to be in the office suite and immediately available in order to meet that requirement. So I think that's a tricky one because it becomes very difficult to discern which Minor procedures have a 10-day global surgical indicator and which do not. And I think that would be a significant administrative challenge and potential compliance challenge as well. So CMS is seeking comment on whether to adopt that particular definition. If you feel strongly one way or another, I would encourage you to go into the Federal Register, and it's really quick and easy to submit comments, even a brief comment on just one topic like this one, if you have them. And CMS addressed direct supervision as it pertains to teaching physician services. Right now, there's always been a requirement that when you have residents involved working with a patient, if a teaching physician wants to bill for an encounter or service, the teaching physician has to be present for what's called a key portion of the service or a critical portion of the service. And flexibilities during COVID-19, which have been extended afterward, have allowed that key or critical portion of the teaching physician to be done through virtual presence by joining the session virtually rather than being there physically in person. CMS is not proposing to extend that current policy. The only exception would be if the resident and the patient are having a telehealth service, then the teaching physician's key portion or critical portion presence could also be met virtually by telehealth. Otherwise, if the resident and the patient are having an in-person service, the teaching physician would have to be physically present for a key or critical portion of that visit. So I'm going to switch gears a little bit, still in a sense talking about codes and services that very much may interact with what you are doing in a telehealth format or telehealth modality. But this is really geared more towards new services or clarifications on how different codes are to be billed and how they will be paid. And in 2026, Medicare is proposing to allow HCPCS code G2211. G2211 is an add-on code describing the inherent complexity of evaluation and management services when the professional billing this service has a longitudinal, a long-term relationship with the patient. So think like primary care. And this add-on code can essentially be reported for most of those professionals' evaluation and management services. And CMS says for next year, CMS would also allow that add-on code to be used for certain codes in the residence evaluation and management visit codes within the CPT book, not just office visits or hospital visit codes. CMS would also create optional add-on codes for certain advanced primary care management services that can help with behavioral health integration and remove some of the time-based coding requirements for behavioral health integration and chronic care management. Those add-on codes, if I go back one slide, those proposed add-on codes for certain advanced primary care, like behavioral health integration, like chronic care management. Those would be considered designated care management services. What that means is they can be performed under general supervision, not direct supervision. Direct supervision from Medicare typically means the supervising professional is in the office suite and immediately available to provide, intervene or provide assistance. But general supervision is more relaxed. The supervising professional just has general overall responsibility for the management and the oversight of care and services. So these add-on codes for advanced primary care, for behavioral health integration, and chronic care management, they can be done under general supervision. It makes perfect sense because the main codes for behavioral health integration and chronic care management are already designated as general supervision, care management services. So one thing that CMS is seeking comment on for advanced primary care services is how they should account for certain components of advanced primary care that may actually be preventive services. And certain preventive services that are covered and paid by the Medicare program have no member cost sharing. So CMS is kind of looking at packaging a bunch of primary care services together that you would report monthly, kind of like chronic care management, that is a monthly management service, but more for just general primary care. It almost looks and feels like a capitated payment, but it's not. But it encompasses a package of services each month. And CMS says, look, if some of those pieces are preventive, how should we account for the overall cost sharing of that service? And now from here on out, you're going to see CMS really posing more questions than answers. For example, CMS is seeking comment on whether they should or how they could start to make payment for providers' investments into software that they're purchasing, software as a service like AI, things that are making them more efficient, more accurate, improving quality of care, creating care alerts and things. And CMS has kind of explored this possibility, saying we really don't account for software in the practice expense calculations on how we value services. So raised that as a possibility. Lots and lots of focus and questions on how CMS can better value and pay for the prevention and the effective management of chronic disease. And I won't read all of these to you, but we will send the slides out afterwards. And I think it's just really good to get a sense of what CMS is asking about, because it gives us a sense of where they're going with some of their future policies. Whether they should create separate coding and separate payment for motivational interviewing and health coaches, getting people motivated to manage their health better under the Medicare program, with the idea that that would reduce overall utilization and costs under the program. Just some really interesting requests for feedback and information that they're soliciting. And with our last couple of minutes here before we open it up for questions, I want to talk about a few provisions that are specific to RHCs and to FQHCs. So CMS is proposing that RHCs and FQHCs report the individual codes, the CPT or the HCPCS codes that currently comprise the billing code G0512, and any kind of chronic care management that you currently would sort of bundle into or loop into that one code, the actual individual codes would be required in 2026 if that rule is finalized. Similarly, payment for communication technology-based services. There's 5 minutes or more, and then there are many G codes for incremental units of time beyond 5 minutes that CMS would have RHCs and FQHCs specifically report the exact individual code. And then the payment rate, rather than kind of a weighted average, no matter what individual service you performed and billed under the codes like today, when you report the individual code for chronic care management or communication technology-based services, the amount of payment would be based on the national non-facility, that's the higher physician fee schedule payment rate. CMS clarified that for RHCs and FQHCs, CMS believes that direct supervision can be provided via two-way, real-time audio-visual telecommunication technology. So that's a little bit different than what CMS is deciding on the regular physician fee schedule rules and policy requirements. Now, September 30th is a very important date for RHCs and FQHCs under telehealth policy because absent an act of Congress, RHCs and FQHCs will not be eligible to perform telehealth to Medicare beneficiaries as distant site providers. So for example, if the patient is at home and an RHC or FQHC provides a telehealth service, today that could be covered under Medicare, but not necessarily on October 1 of this year unless there is an act of Congress that changes that. If that were to happen, if Congress were not to act or to extend or make permanent that particular piece of telehealth policy under federal law, then CMS is proposing on a temporary basis to still have a mechanism to pay for medical visits at RHCs or FQHCs furnished via telecommunications technology. And it would closely align with today's payment methodology. You would continue to bill for those medical telehealth services using the audio only that are performed using audio only technology by reporting G2025 on the claim. That is true whether it is a live two-way audio visual telehealth service or audio only. And CMS, from an agency perspective, would continue on a temporary basis to make payment to RHCs and FQHCs in that manner if we don't get a bill by Congress October 1. That's unique to RHCs and FQHCs. That is not necessarily or likely not what CMS will be doing outside of the RHC and the FQHC setting. Okay, so we've got about 8 minutes until the top of the hour. I'll pause there, Haley, and see if we have any questions I can help with. And I'll try my camera again and we'll see if it works a little better here at the end.
Of course, yeah. Thank you so much, Rochelle. I feel like you always do such a great job of getting us caught up on those proposed changes. So thank you so much for all the information. We did have a few questions come in the chat. Arlene would like to know, would the accountable care organizations fall under APM rates or non-APM rates with these new changes?
Yeah, that's a good question. Let me double check. If memory serves me correctly, that would fall under an advance payment model at the higher conversion factor rate.
Perfect. Well, yeah, we can double check and then get you that confirmed answer. But thank you so much for your question. And then Madeline would also like to know if you could please clarify what SLP services could end on September 30th without an extension or permanent role. Just looking to see if it's all SLP telehealth services or if it's only the services at a distant site delivering Part B services.
Yeah, this is such a good question, and it's sticky and tricky. So thank you for having me go over it again. And I'm going to say this is for speech language pathology, but it also, the same concept applies for physical therapy and occupational therapy. There's a couple of pieces that have made it difficult historically for those three therapy disciplines to provide telehealth services to patients who are covered by Medicare. First and foremost, prior to the COVID-19 public health emergency, they were not eligible distant site providers of telehealth services. And during the public health emergency, CMS broadened that list to say anybody who enrolls in Medicare, you can bill telehealth as a distant site provider. You would be eligible. So that's one piece. But the second piece is the actual specific services and the codes that describe those services must be on the list of covered telehealth services. There's two pieces. Even though for a while there was this expansion saying anybody who bills Medicare could provide telehealth, if there are no codes within their scope of practice on the list of covered telehealth services, they still wouldn't have been able to deliver, bill, and be paid for those services. So right now, We're still under a flexibility where all three of those therapy disciplines are eligible distance site providers and billers of telehealth under the Medicare program. And the list of services that they provide, many of them have been added to the list of covered telehealth services, like evaluations or I think some therapeutic exercises or modalities. I'm not sure specifically for speech language pathology, but there are a number of codes on the list of covered telehealth services. On October 1, absent an act of Congress, those three therapy disciplines would no longer be eligible distant site providers of telehealth services under the Medicare program, even though the codes for the specific services that they provide would still be on the list of covered telehealth services. So it would be tempting and easy to look at that list and say, oh, well, since a speech language evaluation is there, that means I, as a speech language pathologist, can do that via telehealth and bill and be paid. And that's not necessarily going to be the case.
Thank you, Rochelle. Our next question, for direct supervision via telehealth, would you recommend that the medical records state who was immediately available if needed?
Yeah, that is a great question. And it's actually, excuse me, it's actually a question providers using incident to billing rules under Medicare have grappled with for a long time, because the supervising professional is typically listed on the claim form I want to say it's field 17 of the paper form. I'm kind of visually trying to point to it, or its electronic equivalent. Their MPI number is listed there with an indicator saying they were the supervising professional. What that means when you submit the claim is that is the professional who was either physically on site and immediately available, or who was there available through virtual presence to intervene. Best practice would be, yes, to identify who that professional is and to make sure that is the professional identified as the supervising provider on the professional claim form, if you're using a professional claim form. That's really hard and tricky to do. The kind of next best, or what a lot of especially larger organizations do, is they just have a mechanism to know who was the responsible provider. They make sure that provider was on that day, not on vacation, not on overseas or sick or otherwise out of the office, but it was a provider who was actually working that day and who would have been available.
Thank you, Rochelle. And then one last question, just kind of clarifying, in relation to urgent care services specifically, will providers be able to provide telehealth services from home, or within that service, will they need to be in clinic?
Okay, so I think, Haley, as you're looking at that question, is it asking about the provider's location being at home versus the patient?
Yes. So will providers be able to provide the services from home, or will they need to be in the clinic specifically?
Yeah. Yep, that's a great question. And there's no prohibition as long as the professional delivering the telehealth service to someone who has Medicare is a discipline or a licensure who is an eligible distant site provider of telehealth. They could be located anywhere that they're authorized to practice. So you have to be licensed in the state where the patient's located. That gets a little bit tricky. We could have a whole session on that. So long as the physician has a license where the patient's located, the physician or other professional can be located at home and still deliver that telehealth service. Yes. The patient's location the rules on October 1 may impact that under the Medicare program. If there's an extension and everything stays the same, there will be no geography limitation. The patient could be at home. All of that will work the way it does today. If there's not an extension, then the patient would physically need to present to an eligible originating site, but that distant site professional could still be at home. If that's the case, What we may likely see over the next year or two is some evolving policy on whether or how the service location of the distant site professional gets identified on the claim form. Right now, physicians and professionals are not required to enroll their home as a practice location and report that on the claim form. They can use their regular practice location unless they are routinely, systematically providing services from a location, and then they may need to add it as an address. And CMS is trying to think through and balance how do we get the accurate service location for payment purposes, with while also balancing like professionals' privacy and their home addresses and violence against healthcare professionals when that data becomes publicly available as a Medicare enrolled provider. So we'll see some policies, I think, evolving in that area too.
All right, well, thank you so much, Rochelle. Thank you so much for answering all the questions and again for all the information that you provided for us and our audience today. Just as a reminder, if you would like a certificate of attendance, please do email us at htrc@kumc.edu. Just give us a little bit of time to process those and we will get those sent out sometime next week. But thank you all so much for joining us and have a good rest of your day.